Thank you so much, Greg, and thank you all for being here today. And Neely, thank you so much for hosting it. And it's the story of your brother is close to all of us, and I think that's part of the reason why we do the work we do. And I do think, Jenny has been amazing. She's been doing this, and patient education has been a big part of what Myeloma Crowd does. And, I don't want any of this to seem overwhelming, because it's not going to be. Those of you, everybody is at a different time in their journey with myeloma. I think the important thing for you all to know is we are all so hopeful about this disease today. And the things we have to offer for patients now, which probably your brother was not able to see, has been absolutely phenomenal. And part of the reason why we have that is, of course, we have incredible colleagues that we work with, but I cannot underscore how important it is for us to have you involved in all of what we do, because whatever we learn, whether it's from a clinical trial or just you allowing us to use your samples to learn from, has been where we are today. So thank you all for being here and spending your Saturday here, and also for all you've already done for myeloma. What I was asked to do today was talk to you about diagnosing myeloma, monitoring myeloma. So we'll talk a little bit about the workup of myeloma. So I'm going to go down to real basics here. I'm going to talk a little bit about risk stratification, and then how is it that you should be watching your myeloma as you're getting treated, and then also touch on some of the new laboratory techniques that we have in place, which are not quite ready for prime time, but it's nice for you to hear about them, because that's where we hope that the future of myeloma will be. And this is just a cartoon kind of telling you about what myeloma does. And, myeloma is not that simple a disease. It affects a whole lot of different organ systems in your body. And that's why sometimes it can be quite hard to diagnose myeloma. Now, most of us who treat myeloma for a living, by the time you're diagnosed by your primary care physician. And by the time you come to us, it's not that difficult to pick that up. But at the outset, the diagnosis of myeloma can be difficult, because some of the symptoms associated with myeloma are pretty general kind of symptoms. You're just tired, may have a little bit of body ache here and there, and sometimes it can be difficult. So it affects different systems in your body. Part of it is these myeloma cells live in your bone marrow, and therefore can affect the blood system. The bone marrow, as you all know, make normal blood cells. It makes your red blood cells, your white blood cells, and your platelets. Your red blood cells are the cells which give you energy. The white blood cells are your infection-fighting cells, and your platelets are the ones which, if you get a cut any place, that's the clotting mechanism in your body. They prevent you from bleeding out. So if you have myeloma and you have too many of these myeloma cells in the bone marrow, you can have any of these systems impacted and any of these blood counts affected. The other organ which we actually do worry about with myeloma is the kidneys, and that's the thing which your doctors are going to talk to you about over and over again, because the myeloma cells produce a protein, as you all know, and we'll talk a little bit about that protein. And that protein tends to be sticky and can go and block your kidneys, and by doing so it can impact your kidney function. So most times your doctors are going to tell you to drink lots of fluids, keep yourself hydrated, because you're trying to dilute out that sticky protein and trying to prevent it from depositing in the kidneys. The last thing in here is your bones. I do a lot of work in the lab as well around bones, and bone disease is seen in the majority of myeloma patients. I would argue that, if you look hard enough, 100% of people will have some kind of bone problems, and the bone disease can cause a lot of the problems, the pain, fractures, things like that. So trying to prevent and preempt that is quite important in myeloma. In terms of diagnostics, we've come a long way. In the old days, we did the SPEP. We'll talk a little bit about this. This is your bone marrow test. And then we did X-rays. And since the last 10 years, we have a whole bunch of newer tests that we are doing also. And I'm going to touch on them so that you understand what these newer tests are as well. So how do you diagnose myeloma? Now, when you suspect myeloma, typically it's in your primary care physician's office. We do what's known as the serum protein electrophoresis test. It's a blood test, and this is the one in your, the pointer is not showing out there, but this is what it looks like. I think I should use this here. So this is most patients with myeloma have this immunoglobulin. So it's your monoclonal protein, and everybody with myeloma has a different monoclonal protein. Most patients have an IgG something, others could have IgA, it's typically IgG or IgA. And once you have this, you suspect myeloma. Sometimes you will find it in the urine as well, which is why you test both your serum and your urine for this protein. We generally run this on a gel, and we can identify what this protein is. Once you have this protein, we know that this protein is coming from your myeloma cells, which typically live in your bone marrow. So we go in and do a bone marrow, and this is what your myeloma cells look like. They're essentially plasma cells. Plasma cells are immune cells. All of us have plasma cells, so if I did a bone marrow in me and looked under the microscope and counted 100 cells, I'm going to have about 5 of these are going to be these plasma cells. So why do you end up getting myeloma? What tends to happen is there's something which goes wrong with these plasma cells, and we don't completely understand what that is, but what ends up happening is these plasma cells start growing and replacing the bone marrow, which is why you're seeing a complete replacement of this. And the normal function of these plasma cells is to produce this protein that I talked about. Now, if you have an excess of these plasma cells being produced, you're going to get an excess of that protein, but because they're being produced by abnormal plasma cells which don't function well, the protein which is produced, which typically helps you fight infection, it's an antibody which helps fight infection, but if you have an abnormal one, it's not going to do its job right. And that's the monoclonal protein which most of your doctors are talking to you about. We can actually identify that, and we can tell you whether it's clonal or not. When I say clonal, whether or not it's cancerous or not. The other advance in testing has been in the last, I want to say 10, 12 years now, which is the serum-free light chain assay. So when you do the SPEP, this is what the immunoglobulin looks like. This is the immunoglobulin, and this is what your plasma cells produce. This is the protein that we're talking about. And what it has is this heavy chain, and attached to this heavy chain are these little particles called the light chains. And the light chains come in different flavors. So we talked about the heavy chain, which is IgG, IgA, or what have you. And these light chains come in 2 flavors, kappa and lambda. And what we can now do is detect these in the blood as well. So a lot of patients, not a lot, but about 10 or 12% of patients will not produce that immunoglobulin, but will just produce the light chains. And it could be, you could end up having just kappa light chain myeloma or lambda light chain myeloma. So we're able to detect all of this quite well. You are going to hear about genomics from Dr. Davis later on, and what we have begun to understand is, those plasma cells that I showed you in the bone marrow start growing in excessive amounts, and there's some genetic dysregulation in those plasma cells which cause them to grow. And what's happened over the last 15, 20 years is we've begun to understand what the genetics of those plasma cells are. So these are some of the common genetic features which you see in those myeloma cells, and this is a test. When you get your bone marrow done, most of your doctors will be looking for some of these deletions, translocations on those plasma cells, and we have a good sense of what are the percentages of these, and we also have a sense of how these in fact will impact your myeloma. Some of them will portend a slightly higher risk to your myeloma, and that's important for us to know so that we can pick treatments based on how we end up risk stratifying patients. So we have classified these translocations and deletions into these risk categories, which are generally accepted by all. And this is how we actually look for these translocations. So this is a test called FISH test. FISH stands for a fluorescent in situ hybridization. Those plasma cells which I showed you, we actually stain them in a separate way. We look under the microscope and we can begin to tell whether or not you have all of those, the DNA in those cells have any of these translocations, and we can pinpoint this. So when you get a bone marrow done with your hematologist or your oncologist, it's important to get this FISH testing done at the outset. There are other tests that we end up doing also, and those are looking for certain proteins which are important, one of them being cyclin D, the other one being FGFR3, and these are all proteins we've learned about over the years, and some of these are critically important, and the reason I think they're important is we will in the future have drugs to target some of these different translocations, hopefully, and some of these proteins also. There are drugs in development to try and target this. So again, we have these risk stratification criteria, and it's not just based on the FISH, which I just showed you. We do cytogenetics. Cytogenetics is when we take out your plasma cells and we grow them out in culture, and we look to see if there are any genetic abnormalities in those. And I will tell you that the majority of myeloma patients don't have cytogenetic abnormalities because myeloma tends to grow slowly. Those cells don't rapidly proliferate, and that's why you're not going to see that happen. But nonetheless, this gives us a lot of information and allows us to get a sense of how aggressive the disease is and so on and so forth. So having this testing done on your samples is quite important going forward. We talked a little bit about bone disease, and I did mention that bone disease is an issue which is seen in the majority of myeloma patients. And when you think about bone disease, the way I think about it quite simplistically is, bone disease in myeloma is an extreme form of osteoporosis. So when you take a normal person, you have two kinds of cells. You have bone-forming cells and you have bone-destroying cells. And they kind of live in tandem, and they live to work together, and they keep forming new bone and getting rid of old bone. That's what normal bones do. What ends up happening in myeloma is this is completely reversed, such that the bone remodeling, so the bone-forming cells don't really work at all, and the bone resorpting cells keep destroying bones, which is why we talk about those lesions that you've heard about. Those lytic lesions is because of destruction of bone, because those bone forming cells are not really doing their job, and the bone destroying cells are really quite overactive. And that's the reason why you end up seeing, most of you, if you have a diagnosis of myeloma, have had a skeletal survey, x-rays of all your bones. And the reason to do the x-rays of all your bones is to look at these kinds of lesions. So the majority of myeloma patients will have these lesions. That's why it is called multiple myeloma. There are multiple lesions, and I do want to stress out here, because people start worrying about this. I have bone disease, so my disease is at a different stage altogether. No, with myeloma, you begin with bone disease, so you are going to have these multiple lesions. It's unlike other cancers. For example, if you have lung cancer which goes to the bones, it makes it a stage 4 lung cancer, and that's a different way of treating. Not so in myeloma. Majority of patients will have disease from the get-go, and that is why we do not treat this any differently in patients with myeloma. There are newer techniques for imaging also. So the x-rays that I showed you picks up disease in about 60 or 70% of people. but we now have what's called a whole body low dose CAT scan. It's not available everywhere. If you are able to pick up bone disease on those x-rays, that's enough. You don't need to do any more. But if there's nothing on those x-rays, you should press your doctors and ask them to do other imaging. So this whole body low dose CAT scan is actually a very easy way of figuring out problems. You can actually see small little lesions in these patients. It's an easy test. Those of you who've had a skeletal survey, it's not the most comfortable process. It takes about an hour and a half when we are positioning you in all kinds of positions. This low-dose CT is actually very easy. And the hope is that we're going to have this available to people all over. One thing I do want to point out is if you have bone pain and if your x-rays are normal, do not stop at that. You do have to press your doctors to do more. And here's an example of x-rays. This patient of mine was complaining of pelvic pain, and obviously we start out with an x-ray. X-ray doesn't show anything at all, but when you get a CAT scan, you see a big lesion here which would have been missed if we had just stopped at x-ray. Similarly, this guy had a pain in his lower back. X-rays don't show anything, but when we ended up doing an MRI, we were able to see a lesion in that area. So if you have myeloma and you have pain, it's important that you advocate for yourself and get better imaging. And it is quite possible that that better imaging is going to be negative, and if that's negative, that's great. But you do not want to be sitting on a lesion which can end up causing problems. Similar story here as well. You know, radiographs are only as good as they are, and the better imaging you can get, you should be able to do. We are now also doing tests like PET scans. PET scans I reserve for specific situations. You know, if your disease is not producing a lot of protein, for example, and it's hard for you to follow that disease, that's the place where we will use PET scans. In clinical trials and in research, we're using PET scans as a way of monitoring disease. So this was a PET scan on one of my patients who had a lesion in the scapula, had a lesion in the arm bone, as well as the rib, got treated, it goes away. So it's a way of monitoring disease, but it should not be done routinely. And your doctor will know when you need to be doing these PET scans also. So this is again just showing you that this was at the outset in the scapula, that's the wing bone here, and with treatment it goes away completely. What doesn't go away, though, the bone destruction doesn't go away. And when we have time to talk about treatments, you know, we're doing research now wherein we're using bone targeted agents where hopefully we'll start to see healing of bones as well. I'm not going to spend a lot of time on genomics because you have a whole section, but along the way with all of these diagnostics, what we are beginning to do and learn from is whole genome sequencing. Whole genome sequencing is when we look at the DNA in your plasma cells and try and identify the genetic abnormalities. And I think that's important for us as researchers at least to do, because it tells us more about the disease. And what it has allowed us to do is figure out some of these abnormalities. And again, we do have drugs that we can target to these abnormalities. So it's important for the future, wherein as of right now, we have clinical trials where we are using some of these strategies going forward. Well, you know, multiple mutations occur in patients with myeloma, and these mutations can be at different levels. They can be within your clone, they can be within subclones. And again, I'm just going to go over this quickly because I do not want to spend too much time. This is all part of research. I want you to know, just so that we learn more about the disease. There's a lot of genetic heterogeneity in myeloma, and the one point that I will make here is, you know, your myeloma is yours, and everybody's myeloma is a little bit different. And it's unlike some of the other hematologic cancers that we are used to seeing. For example, chronic myelogenous leukemia is a very straightforward hematologic malignancy where it has one genetic problem, and that genetic problem, once it's fixed, we can actually cure a proportion of CML. Not so in myeloma, because the genetics of this is quite complex, but as we keep learning more, we are going to continue to do better with this. And this is just to highlight that whole picture. This is a patient of mine who had his whole genome sequencing at the time of diagnosis, and this is how complex the genetics of that patient looks. And when at the time of relapse, this is what the genetics looks. So it keeps getting more complex as the disease progresses. And it's important for us to understand that so that we have a better way of targeting and treating this disease, okay? So we are doing, at least at MGH, what we are doing is test routinely on bone marrow. We call that the snapshot test. There are other tests around called the foundation medicine test, etc. And what we are looking for here is mutations on your myeloma cells. This is typically when the disease comes back. And the reason to do this is, again, as I talked to you about, if we find some of these mutations, a lot of them are targetable mutations. So you can go after them with specific drugs, which we would not have thought of using if we did not have this information. I do want to spend a little bit of time talking about MRD, and I don't want you all to think too much about MRD, but this is something we are doing in the research world. And what it really shows is MRD is if you are MRD negative, which is minimal residual disease negative, and we have tests that we can use to look for this MRD negative state, this is where we think we can get. So when we treat your myeloma, for example, when you're diagnosed, this is how much myeloma you have on board. And as you get treated, we want to be able to get rid of all of this myeloma so that we can start talking about long-term disease control and actually curing myeloma. So as of right now, I'm going to say that MRD is a research tool. Don't worry about it too much, but it's important for people like Gareth, Faith, and me to work on this so that 2 years down the line we can say, hey, with this treatment we can get X number of people MRD negative, because if we can do that, that would be step one towards curing your myeloma. There's different methods of looking at MRD, and you're going to hear a lot about this. We use flow cytometry, we use next generation sequencing. I've shown you some PET scan data also that can be used, but again, these are research tools. Do not use them in clinical practice as yet. I do want to spend a little bit of time talking about what we are quite excited about, and that is looking at circulating myeloma cells. You know, the one thing I will say before talking about circulating myeloma cells is that, bone marrow, certainly you get at the time of diagnosis, and that helps you diagnose your disease and gives you some of the risk stratification. I will also say that every time you change treatment, I know a bone marrow is extremely uncomfortable, but it's important to do that bone marrow again. And the reason to do the bone marrow again is not because we have a doubt about the diagnosis of myeloma. The reason to repeat that bone marrow is I showed you how genetically heterogeneous myeloma is, and I also showed you how myeloma evolves. So as myeloma progresses, you acquire more genetic abnormalities, and there may be certain things which we will learn from the genetics of your myeloma wherein we can use certain drugs. So obviously, because we know how uncomfortable a bone marrow procedure is, this is one of my colleagues at Dana-Farber, Jens, who's been doing single cell work. We're looking at blood as a liquid biopsy method, and what Jens has done very nicely is he has this robotic. He used to be at MIT and Broad, so he has a little robot who can pick these single cells from the blood, which are actually myeloma cells. And what we have done is compared bone marrow and blood from these patients and looked to see, can the blood suffice, and can the blood give us the same genetic information as the marrow? And in the majority of patients, we are able to do that. Again, not quite ready for prime time, but this is something we're working very hard on. And the hope would be that you don't have to go through multiple biopsies, because that certainly is not comfortable. What we have been able to show also is, even if you have very low disease burden, including in a patient with MGUS, we can actually, with the sensitivity of the technique that we have, we are able to pick up plasma cells even in that situation. There are other methods of doing this. It can be done by flow cytometry. We use certain markers on your plasma cells, and these markers can actually identify normal plasma cells, myeloma cells, and normal B cells quite nicely. We can actually separate out tumor cells from plasma cells, and we can then look at risk stratification by looking at sequencing. So we can do DNA sequencing on these single cells, we can do RNA sequencing, and all the data that I showed you on bone marrow, looking at those cells and those translocations, can in fact be done on these patient cells, and we can subgroup patients into whatever the genetic risk is. Again, similarly, part of the reason to do this is not just to identify the genetics, but also to identify what we can look for in the future. So are there targets on those plasma cells that we can use as targets to treat? And these are some of the targets that we are able to pick up. BCMA is a target you probably are hearing a lot about, which we're very enthusiastic about and are trying to do all kinds of treatments again. SLAM-F7 is the same target, wherein elotuzumab targets SLAM-F7, and these are some of CD138 is something which is commonly seen in myeloma. Again, translocations can be picked up, the ones I showed you, and the future I do think is looking at circulating DNA. So looking at single cells is still difficult. I told you about the robot which has to pick up this, but most myeloma patients will have DNA in their blood as well. So all we would need to do is get a blood sample and check, and in about 50% of people we will not need to do that single cell work. So this is something which is going to be the future, and this is something we're working on very hard. So getting it back down to reality now, monitoring disease parameters. When you're on treatment, most of you will have your monoclonal protein monitored. And generally, when you're getting your initial therapy, it should be done monthly. We should be watching your serum-free light chains, the light chains I showed you. Also, if you have protein in the urine, that's something which needs to be monitored. There's a bunch of other things which should be monitored outside of your myeloma tests. And this is, we talked a little bit about the kidneys. You want the kidney function to be monitored, and typically that is reflected by your BUN and your creatinine. So BUN and creatinine is what should be looked at. For bone disease, we like to look at your calcium levels, your vitamin D levels, and blood counts. You want to look at your hematocrit, hemoglobin, white cell count, platelets, and these are some markers of disease burden, like your uric acid, LDH. That's something which your oncologist will be doing going forward. As you're getting treated, I think it's really quite important to monitor certain things, because it's not just the disease. What we do with the treatment also impacts how you feel, impacts some of your counts. Some of the drugs that we use can cause low counts, anemia, things like that. So all of these features need to be monitored. If you're on drugs like Velcade or bortezomib, watch for the neuropathy. If you're on drugs like the IMiDs, the lenalidomide, pomalidomide, etc., look for thrombosis. Oftentimes electrolytes, so looking at your magnesium levels, looking at your phosphorus levels is important, because when you're on those immunomodulatory drugs, those can go down, and those in fact can be a cause of fatigue. The last thing is, infections are common in people with myeloma, and this is something to be monitored for. You should be getting your flu shot, and if you have any issues, should be treated quickly. How do we choose treatment? We're going to get into that later on in the afternoon session, but we do look at all of these features before we come up with a plan. Obviously important to look at the patient and to see whether or not you have any other kind of issues associated with myeloma. And then of course we do look at genetic risk also to try and determine this. So I do think, learning as much as you can about your disease is going to be important. Understanding your disease is actually going to help you manage it better. And I do think education is very empowering. You're going to be able to go to your doctor and say, hey, you didn't do this, and it's just kind of a check on them. The other thing is which is really, really important to remember, is you're not in this alone. And make sure you have your caregivers with you. They are part of your team. And make sure you communicate with your provider team. So your nurse practitioner, your nurses, your doctors, they're all on your team, and everybody's going to do this together. So this is a journey, and as much information as you can gather, you should have. And always, always, always ask questions if you have questions.